Hi guys, I've got a quick short lecture this week. This is going to be the topic of corticosteroids in topical presentation. So first of all, before we talk about the drugs, actually, I wanted to just review topical preparations in general and just talk about some of the different formulations and how things penetrate different layers of the skin. So basically, there's a couple different things to look at when it comes to formulation. And the first thing and the most important is lipophilicity versus hydrophilicity. So a more lipophilic medication is going to penetrate a lot easier and deeper than a more hydrophilic medication. Now, it kind of depends too. So you could think about it this way, where like something that's hydrophilic, like maybe a lotion or a cream, it's going to absorb those top layers much more evenly and quickly. However, it's also going to get washed off fast. It's not really going to penetrate all that deep. Whereas things that are in a fattier base that's lipophilic, while they're a little bit gooier like an ointment and stick to the skin a little longer, the advantage is that they can penetrate deeper into the tissue because of that. And also they generally don't get washed off very easily. So the more lipophilic the drug is too, is from a molecular standpoint, the further down it's going to penetrate. So when we talk about steroids, steroids are quite lipophilic, and they'll get through most layers. So you can actually get pretty deep penetration of steroids. So you have to be careful when you use a steroid topically someplace that's got thinner skin, because the odds of it getting into systemic circulation are pretty good. And in most cases, it's not enough to really be a big deal. But in some cases, the more potent drugs you use and the more thin skin areas and the larger the surface area you're applying the product to, the more risk you have for systemic exposure. So generally, formulations, we're looking at lotions, creams, ointments, and gels. And so when it comes to water content, that's really the biggest difference here. And everything's made up of varying similar components. But of course, you guys probably know the difference between all these. It's pretty common sense. Gels tend to be the anomaly. Whether or not a gel is going to penetrate deeper or be more lipophilic or hydrophilic really depends on the gel formulation. You can have some gels that are really high potency and actually can penetrate several layers of skin, and you can have some that aren't. It just depends on how the drug company is designing the product and what the intent is. So when it comes to formulations, what you want to think about is patient compliance first and foremost. Ointments might be ideal because they stay on the skin longer and they can penetrate deeper layers of tissue, but in real life, ointments are kind of cumbersome. They can possibly stay in clothing, they can rub off on stuff, and they leave just a greasy feeling on the skin. A lot of people don't like that. So while some people can tolerate it just fine, many people are going to opt for cream instead. And while cream not as ideal of a formulation, in some cases, it still can be effectively used. And we'll talk about the different potencies of different steroids here. And then, of course, a lotion would just be even a more, basically a lotion very similar to cream. It's just more water added to it, so it's a little bit more viscous, absorbs faster. This is a quote from one of the physicians I work with, and he says, this is his dermatology in a nutshell. He says, if it's wet, make it dry. If it's dry, make it wet. Start with steroids, and if that doesn't work, try an antifungal. And I like this quote because it's something that for some reason sticks with me, and I like it because it kind of does sum up very basic dermatology in a nutshell. So if you have some sort of dermatose or some sort of dermatitis of some kind, usually you're probably going to try some sort of a topical steroid first, whether it's eczema or irritated skin or dry kind of patchy, itchy skin or whatever. Steroids can usually work for a really wide variety of conditions, so it makes it a very good starting point. Now, unfortunately, if you have some sort of a fungal infection and you put a steroid on it, it can weaken the immune system locally to that agent, so you can actually get a worsening response. So that's where the second part of that comes in. So if you try a steroid, it doesn't work, it might be topical, like tinea infection, well, it could be like an athlete's foot or something like that, or ringworm. So some of the basics behind these products and the drugs in general. So corticosteroids are thought to be anti-inflammatory, but they also have a lot of other mechanisms involved. So they have what's called anti-meiotic activity, so they prevent cell growth. So treatment of scaling dermatoses can be effectively done by applying topical corticosteroids. And the one problem with this therapeutic benefit is that you can end up with thinning of the dermal layers over time because of that effect. So your skin isn't building up as thick of a layer as it used to. So people who take corticosteroids chronically orally are at risk for this too. And if you use them topically, you're going to be at risk for that in the local areas you're using them. They also induce cutaneous vasoconstriction. So this is a nice advantage for any type of itching or pruritus. And they'll help constrict those blood vessels so that you aren't feeling as itchy. And so those are the two major areas of, or three, I guess. So you've got the vasoconstrictive component, antibiotic activity, and the anti-inflammatory response. So there's a lot of different products and variations of strength, which we're going to talk about here in a second, and there's a ton of different indications. One thing at the bottom that I think is important to remember is that I said earlier is absorption definitely depends on how thin the skin is. So places that have really thin skin, specifically around the genitals and facial skin, are going to absorb at a much higher rate. So blood vessels are much closer to the surface of the skin. You don't have to penetrate as deep through those dermal layers to get to blood and to get to your blood vessels. And if your drug's getting to your blood vessels, there's a chance it's getting absorbed systemically. And then you're at risk for a topical or a systemic effect. And the whole point of using a topical corticosteroid is that you can get the same effect and benefit of them without exposing somebody to side effects of steroids, which are many and vast, and we're not talking about those specifically here because we're talking about topical, and it's generally not a risk, but it is something we would consider being a problem if somebody did get exposed to too much of it. Places with thicker skin, palms of the hands, soles of the feet, and if you do have a place of thicker skin that you're having difficulty with, you can always try having somebody soak the skin in warm water prior to applying the corticosteroid. You might get better skin penetration that way. Corticosteroids mechanisms, basically they're working intracellularly. So your body has a number of different uses for corticosteroids. And so cortisol is sort of the baseline steroid. So hydrocortisone being the over-the-counter product that is a mimic of cortisol. And cortisol will get excreted and will react in a number of ways. And a lot of time it has to do with immune system. It has to do with anti-inflammatory and immune system processes. So you have a receptor system built into cells that gets activated when a corticosteroid crosses through a cell membrane wall and stimulates it. It causes a downstream effect. Messenger RNA is sent out, and you end up with T cell activation, which can cause a ramp up in a variety of things too. So now, if that process is going on, steroids can work on that specific area to prevent it from happening. So you can see how this illustration shows you that you got the steroid crossing over, complexing here, and that's preventing some of this process from occurring. So you're getting inhibition of cytokines and some other things going on too. So it has that, again, anti-inflammatory, anti-immune component to it. All right, so this is a chart that I think does a pretty decent job showing the different steroids that are out there and the different potencies. I certainly don't want you to know all of these for the test. I'm basically going to give you a couple that I think are important to remember. So I think it's always good to know the very high potency steroids. Why? Because I think these ones are ones people tend to go to right away for more severe skin conditions. So, it's kind of like a go big or go home strategy, especially if you're looking at an area of the skin that's pretty thick and doesn't have as high risk of systemic absorption. Or if you're working with a patient who's older, we aren't generally talking about pediatrics here, but if you're working with kids, you would want to be very careful and use a lower potency product. So basically, I think there's a couple things to remember here. So with class 1, that's our highest potency ones up here. Betamethasone, clobetasol are probably the two worth remembering. Those are the two most common topical steroids that are in that really super high potency class. And we're talking about high potency. This class of steroids is 1,000 times more potent than our class 7, which you probably recognize, hydrocortisone, hydrochloride, which is your over-the-counter hydrocortisone ointment or cream. If you buy that over the counter, that's what you're getting. One thing I will point out is you'll notice sometimes things can move potencies depending on the vehicle they're in. So let's find an example here. Sure, it won't take me that long. Oh, here's one. So betamethasone as a cream versus betamethasone as an ointment. Same percentage, versus a gel or an ointment, I should say. Same percentages, just different vehicles. So remember, the vehicle can have an impact, and of course, gels, ointments, or ointments for sure. Gel's generally going to give you more. Clobetasol itself is just a super potent. It doesn't really matter what you give it in. So if you want a high potency steroid that you don't want to have to give an ointment in, clobetasol cream will be a fairly effective choice there. And then all the way on the bottom are hydrocortisone products. These are important, I think, to remember because patients can buy these over the counter. They don't need a prescription. It's really a good baseline to try and see if it works. There's a lot of people that I've worked with over my years that tell me that they don't think hydrocortisone really does anything. It's sort of a placebo effect, and that's very possible. Personally, I will put it on mosquito bites or whatever. I get that's itchy, and I feel like it does have some effect. Maybe it's in my head. I don't know. It's possible. But I think it's worth a shot. It's relatively benign, especially if you have an area you're trying to treat that is in those thin skin spots that we talked about. So facial skin, genital skin, and that's going to be a very conservative approach you can use. And then the other thing I would point out are mid-potency ones, and that's where things get really muddy. So you're probably thinking, what if I don't want really high potency, and what if I don't want really low potency? Well, that's where our friend triamcinolone comes into play. Triamcinolone cream is probably the most common steroid prescribed, and the reason is because it is a mid-potent steroid. It's much more potent than hydrocortisone over the counter, but you aren't quite getting to the point where you're at these super high potency steroids. So it's a nice balance, and it's literally almost directly in the middle. And you can see if you want a little more bang for your buck, you can go up a class and use the ointment here. There's a couple other things in here to consider. You know, some people use fluocinolone. That's a relatively common one too. But if you're thinking about mid-potency steroid, I'd really remember that triamcinolone. From a test question point of view, pretty much I'm just going to ask you about 5 different steroids. So I want you to know class 1, high potency betamethasone and clobetasol. If you see those, you should think high potency. Classes aren't important. Just think potency wise. So very high potency betamethasone, clobetasol, mid potency triamcinolone, and low potency hydrocortisone. So I think I said 5. That's actually what? 4. So you only have to really know 4. So that's not hopefully too much to ask. But do remember that that's not an absolute rule. So while I'm not going to test you on all of these because it'd be ridiculous to try to do that, I do want you to keep in the back of your head that you can have a product like, look at this betamethasone valerate lotion, 0.1% lotion, is class 6 low potency, and then you go all the way up to betamethasone. So betamethasone is very formulation dependent, and also depends on the salt formula too. So valerate versus dipropionate, you're going to have a much different ability to penetrate the skin because the molecule's able to move easier depending on what salt it's coupled to. At the same time, you see betamethasone valerate ointment, which also moves up way higher than the betamethasone valerate lotion. So just remember, vehicle is really important too, but I do want you to focus on knowing a couple of these and where they fit in. Again, betamethasone, clobetasol, high potency, triamcinolone, mid potency, and hydrocortisone being a low potency steroid. And this basically just says what I already talked about. So you have, again, your super high potencies. Pretty much consider these non-facial, non-genital. Even in a really severe situation, you probably wouldn't want to consider using them there, just because if you do start absorbing these, that's a lot of steroid in your system, and potentially. So it's something that, if somebody started absorbing some hydrocortisone because they applied it to their face, we aren't really too concerned about that because it's low potency, it's low percentage, it's probably not going to get all that much of a systemic effect. When you have these drugs, they might be so potent that they do actually bring out more of an effect than what we'd want. And then I just talked about where you might use things. So palm soles, thick skin, high potency, you can kind of go nuts with it. And you probably aren't going to really even touch systemic circulation in those areas. Medium high for mild to moderate dermatoses. And then large areas of the body. So think about if you have really big surface areas to cover, you really want to be careful. And that's where probably drugs like a triamcinolone would come into play, where you can cover a pretty large surface area and get an effective product, but you aren't exposing somebody to a lot or a super high potency steroid in a lot of it. And then stick to the lower potency items if you're looking at genital or eyelid treatment. As far as duration, is there a specific time frame? I think this is important to remember. So for daily use, if you're using a super high potency steroid, I wouldn't use it more than 3 weeks. Problem is you're going to thin out the skin. Could make things worse and more irritated potentially. Some lesions may require longer treatment, and if they do, you want to maybe consider backing up the strength of the product. So 6 to 8 week period, using maybe a more middle high strength or maybe a more medium strength product. Low potency, it's pretty much no risk unless you're applying it to like your entire body. You can pretty much, again, go crazy with this one. You aren't going to do a whole lot of harm. And then some people might try intermittent therapy, which can be really effective. So like twice weekly super high potency steroid can give the skin some time to heal on its own with also treating the issue at hand too. And that works well for some patients. So definitely consider your options here. And again, children, not really talking about children here, but usually a lower dose, lower potency. For pregnant and lactation patients, or lactating patients, you might think about just being careful. So steroids are a bit of a mixed bag when it comes to pregnancy and lactation use. There's a number of kind of unusual pieces of evidence that say, not to breastfeed with corticosteroids. Generally speaking, everything's looking at systemic when you're like talking about studies. So with topical products, there's not a lot of data to say one way or the other. I think generally speaking, they're fine, especially if you're using a mild a moderate or low potency product. That should probably say here, low potency. Sorry, I'm using the wrong terms. Low to moderate potency. A super potent product, again, you're just running the risk of getting systemic exposure more so than with a low potency. So I know that there are plenty of uses for low potency, medium, moderate potency steroids that could come into play, especially if somebody's having a lot of irritation around their nipple from breastfeeding. They could possibly need something like this. So in that case, you want to maybe consider it. But ultimately, just remember to weigh the benefits and risk of what you're using, which is Katrina will do a lot more on pregnancy and lactation, but that's kind of the rule of thumb. When you have a lot of this stuff that we just don't have really good information to support one decision or another, it's probably safe. But again, if you read the literature on systemic, there is some mild controversy about using them in pregnant and lactating patients. All right. Side effects, we talked about the cutaneous skin atrophy. Dry scaly eruptions can come about, and people might end up with allergic reactions. If they do get an allergic reaction, it's probably, and I'd say almost 99.9% of the time, going to be related to the vehicle, not the actual steroid. So don't think, oh, they reacted to triamcinolone. Try maybe a different manufacturer of triamcinolone, or maybe go from a gel to a cream, or a cream to an ointment, or something like that. Or maybe pick another one in the same category based on that table I gave you. Systemic, again, steroid systemic effects should not be a big deal when it comes to topical. However, you can suppress the hypothalamic pituitary axis by providing the body with excess steroid. And if you're using that for a really long time, especially if you're using high potency, large surface area, broken skin, so it's getting absorbed directly into the bloodstream, none of those are things we want, but it can happen potentially. In that case, you could get some axis suppression. And if that does happen, and you stop the steroid, the person's body is going to go into a bit of a shock state because their body's not used to making its own cortisol because it's used to getting it from somewhere else. So then they can go into a bit of a problematic period where they could be at risk for a lot of different immune-related, inflammatory-related complications. So we want to make sure that we're watching that carefully. And patients can get hyperglycemic too if they're getting a lot of systemic exposure. So again, minimal risk here, but it is worth discussing briefly. As far as clinical applications, really steroids can run the whole gamut of your dermatologic infections, or not infections actually, but complications. So I've listed a few here. Chronic disease, psoriasis, you could use it maybe for smaller lesions. Most people who have psoriasis are going to be taking something more systemic to suppress the plaques from coming up, but you can use steroids too. And there's, again, a ton of applications. So just wanted to give you the basics, and that's all I've got for you today. Thanks for listening.